Hi, this is Dr. Robert Fox from the Cleveland Clinic. I would like to share with you some updates on progressive MS from the annual Consortium of MS Centers meeting. The title of my presentation is Progressive MS. Where are we and where do we go from here? The first presentation I would like to discuss was given by Dr. Bruce Trapp, who is a neuroscientist at the Cleveland Clinic. Dr. Trapp evaluates brain tissues derived at autopsy through the Cleveland Clinic Brain Bank. He evaluated for gray matter pathology. Now, it's been long known that MS affects white matter, and in recent years there's been an appreciation of the gray matter being involved with multiple sclerosis. Dr. Trapp evaluated tissues from the brain bank and found that 13% of tissue donors had no macroscopic or obvious to the plain eye white matter lesions. In addition, these brains were evaluated using MRI, and there were no white matter lesions found on MRI. But surprisingly, he found prominent demyelination involving the cortex and the spinal cord. In additional brains, there were some T2 lesions, but only 3% of the regions with T2 lesions showed demyelination, where typical MS brains show over half of the T2 lesions show demyelination. There was activated microglia and astrocytes, so showing tissue damage, but no demyelination. So what he observed was that not all T2 lesions represent demyelination. And whereas clinicians, when we see T2 lesions on the MRI, we think this always represents demyelination, but it doesn't always. And there is a subset of patients for whom even the small amounts of T2 signal change or T2 lesions don't represent demyelination. This is helpful when we see patients because some patients seem to have a lot of cognitive difficulties, but they don't have much MS on MRI. But that's just MRI that looks at the white matter. We do know that demyelination in the gray matter is typically not seen on the conventional MRI, and this gives some insight into those types of patients where there is not much injury obvious on the MRI in the white matter, but there can be profound demyelination that affects the cortex. Further research is needed to develop better imaging methods so that we can appreciate that demyelination that affects the cortex and the spinal cord before patients go to autopsy. Second study I'd like to discuss was delivered by Dr. Fritz as part of the Whitaker Track. It's been well known that injury to the cerebrum, or the upper parts of the brain, relate to cognition, and injury to the spinal cord relates to ambulation or walking. But what about the cerebellum? Dr. Fritz and her colleagues evaluated the cerebellum to understand how injury to the cerebellum, as measured by atrophy and diffusion tensor imaging, which is an advanced MRI measure, how these MRI measures relate to performance. What they found is that MRI measures in the cerebellum, both diffusion tensor imaging and atrophy or shrinkage of the cerebellum, they correlate with walking, with strength, with cognition. They measured walking with a 25-foot walk test, the timed up and go and ability to stand up from a chair test, and a 2-minute walk test, which is how far one can walk in 2 minutes. What they found is MRI measures in the cerebellum correlated with those measures of walking. They also correlated with strength and even correlated with the frequency of falling as reported by the patients. They then went on and correlated cerebellar injury to cognition as measured by the symbol digit modality test. And again, they found correlations between injury to the cerebellum and cognition. So this study shows the importance of the cerebellum, an often forgotten brain structure, to many functions that are impaired in people with MS. The next study I'd like to discuss is actually two studies that looked at predicting disability progression. and trying to understand who is more likely to develop disability or progressive disability over the course of their disease. The first study by Dr. Ben-Zacharia from Mount Sinai School of Medicine evaluated 150 MS patients followed over 5 years. And they looked at obesity as measured by body mass index and the risk of progressive disability. What they found is that both patients being overweight or being obese, that was associated with increased risk of progressive disability. In fact, being overweight or obese was associated with an 8 times increased risk of progressive disability. Now, it wasn't just correlated with disability, but also active inflammation. So there was a 2 to 6 times increased risk of new brain MRI lesions in the overweight and obese patients. There was also an increased risk of slowing disability as measured by the 25-foot walk test in patients who had an elevated body mass index. Finally, they also looked at smoking and the impact of smoking with disability progression, and they found that smokers had a 5 times elevated risk of increased disability. So in summary, they found both obesity and smoking appear to have an important role in the progression of MS. And perhaps most importantly, these are modifiable risk factors that can be addressed with MS patients, both being overweight and obese, as well as smoking. The next study by Dr. Muller at the University of Massachusetts looked at a clinical database of 4,000 MS patients. And they used this database to identify predictors of evolution to secondary progressive multiple sclerosis. So what they found is that slower 25-foot walk during the relapsing remitting stage predicted conversion to secondary progressive MS. So this is important because this was a very early course, a predictor at a very early time during relapsing remitting that predicted those that would convert to a progressive course later. Importantly, they also identified 8 seconds as a dividing line between in predicting those who were more likely to progress to secondary progressive MS. So even if the patient still had relapsing remitting MS, if the time it took them to walk 25 feet was over 8 seconds, that increased their risk of developing secondary progressive MS later. So this was a helpful predictor in the evolution to secondary progressive MS that is very easy for any clinic to measure. So just measuring the time it takes a patient to walk 25 feet, that can be useful in identifying those at elevated risk for developing progressive MS later. Finally, I wanted to share a study by Dr. Henneghan, who identified predictors of self-related cognitive difficulties. So cognitive difficulties are very common in patients with MS, and particularly self-rated cognitive difficulties, so patients saying that they have difficulty with their cognition. Sometimes that can be a more important problem for patients than even objectively measured cognitive impairment, that being patients feeling like they have difficulty with memory, with concentration, with multitasking, and things like that. So Henneghan and colleagues looked at 300 people with MS and looked at their self-reported cognitive difficulties and its relationship with other MS symptoms. What they found was that the typical predictors, age, disease duration, and years of education, did explain some of the self-reported cognitive ability, but only a very small proportion in the variability of reported cognitive ability. So yes, age and disease duration and years of education were correlated, but not very strongly. Importantly, patient-reported perceived stress, depression, pain, and fatigue, they were much more strongly correlated with the perception of cognitive difficulty. The reason this is important is because stress, depression, pain, and fatigue are all things that can be addressed in patients that may therefore improve their self-rated cognitive ability. Now, this study didn't go that far to say if we improve depression or pain or fatigue or stress, we can improve their self-rated cognitive ability. But it does point to the possibility that given the strong correlation between stress, depression, pain, and fatigue with patient-reported cognitive ability, that if we can address those things, we might be able to improve patient self-related cognitive ability. So as you can see, there were many different advancements in progressive MS, from understanding some of the pathology in the cerebellum and in the cortex and the spinal cord, also understanding some of the predictors of progressive disability, and perhaps most importantly, some of the modifiable predictors of self-related cognitive difficulties that point towards opportunities that we can address with patients in the clinic to help improve their function out in daily living. Thank you very much for joining this program.